This, I invite Dr. Manju Anup, a very important topic, very relevant topic. Not all IOPs need a drop. Red flags before you treat a glaucoma.
Good afternoon, all. Thank you, Divya, for giving me the opportunity. So, what is ocular hypertension by definition? It is intraocular pressure more than 21 millimeters of mercury with Goldman applanation tonometry in
One second, Manju. Slide not started. Okay.
Yeah. So, in one or both eyes on 2 or more occasions. Sometimes, usually with NCT, we do check the intraocular pressure and it may show high, maybe somewhere 22, 23, and the patient might be started on medication. It doesn't mean that the pressure is accurate. So, if you seeing a pressure rise with NCT, kindly do it on applanation tonometry, and minimum 2 to 3 readings are required to make sure that the IOP is high. And another most important thing is gonioscopy. Gonioscopy should show open angles. Otherwise, this primary angle closure can also present as a raised IOP with disc and fields, everything normal. So if you miss the angle closure in this age, this time maybe it can progress to primary angle closure glaucoma, and if you can treat with the PI in the early stage, actually we can prevent the progression in primary angle closure. So gonioscopy is very important whenever you see a patient with a raised IOP. There should not be any evidence of structural or functional optic nerve head damage. Sometimes when you do a fields or OCT for the first time, there can be some error and it can show some changes. So don't club that the pressure is high and the field or OCT which you have done is high, is abnormal, and then directly diagnose it as glaucoma and start treatment. You repeat the intraocular pressure measurement, make sure that it is high, and repeat the field test or OCT to make sure that the defects are reproducible, and then only take a decision. Nothing is going to happen in that short period of time where you confirm your diagnosis. And no other ocular or systemic causes for raised IOP. So now the question is, do you want to treat all cases of ocular hypertension? So this ocular hypertension treatment study has considered some factors, and they have assessed the relative risk of progression to glaucoma in 5 years. These factors include age, central corneal thickness, CD ratio, pattern standard deviation, and the baseline intraocular pressure. And they have given some points to each of these risk factors, and then they took the sum of these points. And if the sum of these points is 0 to 6, the estimated 5-year risk of progression is less than 4%. And if it is 7 to 8, it is 10%. 9 to 10, it is 15%. Then 11 to 20, 20, and more than 12 is 30%. So this is just a rough guideline. They have not taken other risk factors like family history or other systemic risk factors, etc. And they found that if the percentage is less than 6%, the risk is low. That is, the number needed to treat is 1:98. So you have to treat 98% of the low risk patients for them to prevent 1% going in for glaucoma after 5 years. So you don't need a treatment for this low risk patients with ocular hypertension. In high risk patient, that is more than 13%, the risk is 1:7. So you may need treatment in the high risk patients. In the medium risk patient, that is 6 to 13%, it is physician choice, considering other risk factors, their life expectancy, other systemic risk factors. You can decide whether you want to treat at the first visit or you want to wait and document for the progression and then decide on treatment. So let us look at some case scenarios. This is a 64-year-old male with no systemic disease. Everything else was normal. His pressure was 23 millimeters and 24 millimeters of mercury with a central corneal thickness of 560. Discs are healthy. Field test normal. So if you take and add the points, the sum of the points comes up as 5, and the estimated 5-year risk is less than 4%. So this is a low risk patient, and you can observe, maybe initially you can do a 6-monthly follow-up to know how they progress, and then annual follow-up should be enough. At any point of time, if the pressure increases beyond say 26, 27, or if the field changes or OCT changes are appearing, then you can consider treatment. The second case, again 64-year-old, same scenario, but the pressure is around 28 to 30. So here the points comes as 8, and the 5-year risk is about 10%. So here again it is a moderate risk, but since the pressures are around 30, and there is a strong chance of vascular occlusion if the pressure goes high. So because of that reason, I personally prefer to start treatment in case pressure where it is more than 26 or 27. So here the treatment options are topical medication. I prefer prostaglandin analog because of the compliance and single nighttime application. You can even consider laser trabeculoplasty. Case 3, it is 54-year-old male, no systemic disease, and the pressure is 23 and 24, and the central corneal thickness is 520. So the cornea is slightly on the thinner side. Here again, the point comes up as 7, so the risk is about moderate. So here, since the pressures are also slightly lower, you can observe, and 6-monthly follow-up should be enough. Case 4 is a 54-year-old male. There is no systemic disease. Here the IOP is 28 and 29, and CCT is again on the thinner side. So here when you add up the points, it is coming as 10. So the estimated 5-year risk of progression is about 15%. So this is a high risk patient. So better to start treatment and do a 6-monthly follow-up. Again, the treatment options, medical management or laser trabeculoplasty. The next patient is 54-year-old male who came for a general eye checkup. The pressure was around 26, 27 borderline, and her the central corneal thickness was very thin. So CCT is a high risk for progression. Thin cornea is high risk for progression, and the disc is also a large disc. But the fields are normal. So here the point comes up as 12. So this is again a high risk. That is, the pressure is also borderline, very thin cornea, and large disc. So better to start treatment with a 6-monthly follow-up. Again, the options can be prostaglandin or laser trabeculoplasty. So these factors I have given as rough assessment. You have to consider all other risk factors, patients, other systemic diseases, family history, everything before considering the treatment. So to conclude, ocular hypertension with multiple or high risk factors might need treatment. With less or low risk factors, you don't need a treatment at the first visit. You can frequently follow up to detect the earliest sign of progression to initiate treatment. However, every patient with ocular hypertension need a lifelong regular follow-up regardless of the treatment. Thank you.
Thank you, Dr. Manju ma'am, for that key decision points. Actually, I think glaucoma is one of the most misdiagnosed and overdiagnosed disease.
Yeah.
Yeah, in most of these peripheral centers, actually CCT is not available. So they will diagnose the IOP only with the NCT.
Yeah.
And most of them will be having only the Apasami OCT. So the Apasami OCT, ONH, somewhere there will be one yellow line or a red line. Most of them will be starting an anti-glaucoma medication. That is the usual scenario going on.
So actually, when you see an NCT, I think there can be a high false positive IOPs. Most of the time, we do get referral from the hospital, general hospitals, or that other setup, and for the evaluation, they may not start the treatment. But when we repeat the IOP, it will be actually normal. Sometimes, even if ocular hypertension, one OCT reading or one field reading abnormal, you have to repeat the field test or OCT to make sure that the defects are reproducible. Then only you confirm that it is glaucoma. And also all ocular hypertensions, no need treatment. You can still observe and document the progression and then think of starting the treatment. Otherwise, we have to withdraw the medicines and then do a re-IOP check, then do all the investigations, and then the problem is once the other person might have told you have glaucoma and you have to use it lifelong, then to convince the patient that you may not need treatment at this time, it's very, very difficult because it is there in their mind. I'll go blind if I don't continue the medication. So don't jump and start treatment in ocular hypertension.
Excellent, ma'am. Key decision point. Excellent, ma'am.